with some tales to share. John and Dan, unscripted and rare. They talk about life.
Hey, everybody. Welcome back to Unscripted with John.
And Dan, of course.
And Dan, of course. That's
right.
his middle name now,
That's
you
right.
guys.
Welcome to the show.
Welcome back. Hey, Dan,
Yeah.
what does ankles, knees, hips, and shoulders all have in common?
They move, joints.
They are joints.
Oh, okay. That's great.
And here today to talk to us about joints,
That's right.
those body parts that we were just talking about, is my surgeon, my knee surgeon from December 1st, to tell us all about specifically knees, but he'll answer questions for us about hips and ankles and all that other joint stuff as well. Welcome, Dr. Michael P. Leathers from Sacramento. He's a 9-year orthopedic surgeon, a USC medical school graduate. He also went to UCLA and UCSF and got an early start because his dad was also an orthopedic surgeon, very well known throughout the Northern California area. Welcome, Dr. Leathers.
Welcome to the show, Dr. Leathers.
Yeah,
Glad to have you.
Thank you very much for having me.
Well, thank you for joining us, and thank you for doing such a good job on my knee.
Yeah, I guess that's a good sign if you invited me on your podcast.
Exactly, right? Let's start off by asking you a real simple question. Who should and who shouldn't get total knee replacement surgery? Who are the candidates?
It's a great question. There really is no perfect one answer for everybody. It's an individual choice. So I think there's a couple components that you really need to have checked off before you undergo a knee replacement. One of them is pain, disability. So pain that's on a daily basis that, some people define that differently. For some people, it's pain that limits them from walking, instead of walking 7 miles, they can only walk 5 miles. For other people, they don't even want to go up and down the stairs. The thought of walking around the block is scary. Going to the grocery store, they avoid that. So trying to understand how disabled they are because of their knee pain is important. That's definitely a prerequisite for having knee replacement surgery. And then there's some technical things like you need to have arthritis on x-rays, that's for sure. And I would say those are the main, and then age comes into play as well. So
Right.
the younger you are, you want to try to avoid having a knee replacement for as long as possible, and because knee replacements don't last forever.
Well, when someone hears the words knee surgery, that sounds pretty complicated to me. What's involved? What does that actually mean? And what different kinds of knee surgeries are there?
So when it comes to knee surgery and specifically knee replacement, it's a resurfacing. So just like if you went to the dentist and they resurfaced your tooth or put a cap on your tooth, it's the same thing for the knee. So a knee replacement is not just cutting your leg off, cutting your knee out. You get to keep most of your normal anatomy. In fact, all it really is a resurfacing. So the end of your femur bone, we trim the bone off the end of the femur, just enough bone to fit a metal cap. And then on the tibia, we trim off the top portion of your tibia, maybe at 5-10 millimeters to fit a metal cap on the tibia. And then we put a plastic liner in between. And so that becomes the new knee. It's just a new surface. Instead of bone-on-bone grinding, you have metal rubbing on plastic.
Wow.
That's pretty
impressive.
cool.
Yeah, it really is.
How long does that type of surgery take to perform, and how long is the recovery time?
So it's for me, it takes about an hour and 20 minutes, hour and a half to do the surgery. And the recovery, there's definitely a lengthy recovery. So I would kind of divide it up into a couple different components. The initial 2, 3, 4 weeks is definitely, there's some pain, there's some swelling. We're really focused on range of motion, just trying to walk, do your activities of daily living. And then once the pain subsides, the swelling improves, the range of motion is coming back. We can start to be a little bit more active with the knee, doing some physical therapy, using an exercise bike, walking longer distances. And so I would say a majority of the recovery is in the first 4 to 6 months, but I have almost every patient tells me it takes about a year and a half to really improve.
Well, once you get total knee replacement, Are you going to be able to run and things like, what kind of restrictions do you have?
That's a great question. And people are always pushing the boundaries with knee replacements because people want to be active. I think that's important for people. They want to be active. They want to get their lives back. So now, once you get a knee replacement, at least from my perspective, I want that knee replacement to last the rest of your life. And so the more impact you do on the knee replacement, such as running, jumping, or skiing, perhaps, we want to be careful because we want that knee replacement to last 20 plus years.
So are you saying the parts can break or wear down, or?
So the parts wear down or they can come loose. Those are the most common scenarios for which you would need to have a redo or a revision knee replacement.
Interesting. Well, we hear a lot about the robotic knee replacement surgery. What is that specifically meant to fix? Is it the same objective, or is it something different? And if so, how do you think that's improved your ability to do the surgeries?
Great question. Like in a lot of things, robotics has really come into play over the last 10, 15 years, and it's becoming much more common now, even in other specialties, whether it's general surgery for hernia repair or other types of surgeries. Robotic surgery is here and it's here to stay. And definitely for knee replacements, it's becoming more common. One of the things about robotic knee replacement, one of the things that it's tried to help us improve upon is how we make our cuts. Like I said, a knee replacement, we trim the edge of the bone down to fit a metal cap. Well, you can trim a lot off one side, a little off one side. There's a lot of different angles that come into play. So the robot allows you to be really, really precise.
Right here might be a good spot for us to show our viewers that video.
So here you can see video number one. The robot is activated. I'm pulling the trigger on the robot, and that's activated the saw blade, and I'm controlling how far it goes in and out to make those cuts. So the robot's not freewheeling. It's I'm doing the surgery. It's not doing the surgery for me, but what it's allowed is I've picked an exact angle at which I want to make those cuts. And therefore, the saw blade is coming in on that very precise angle to cut just the right amount of bone off that's preset. So I preset that, meaning when we get a CT scan of your knee and then we register the knee on the operating room table, it puts the CT scan information that we get combined with where your body is in space.
Right.
And then I get to pick, all right, we want to put a size 5 femur on. Therefore, we need to trim this amount of bone off. And I want to trim, 4 millimeters here, 7 millimeters here at this angle to fit it what I think is the best way to fit it.
So the robotic knee surgery is only assisting you. You're still in complete control. It looks like you're using a device very similar to this. I use this in my wood shop, Dr. Leathers.
Yeah.
Tell me you've got something a little more advanced.
No, I brought that in this morning. I brought that in that day and just...
Did you? Okay. And by the way, I forgot to warn our viewers that some of these images might be a little graphic, so look away. You just listen to us. There's a little bit of blood and some stuff going on. It makes me even a little squeamish knowing that's my knee. That is actually me in there, folks.
Yeah, I didn't use a tourniquet, and... that's another topic. It's, I think that when you use the tourniquet, it certainly makes it a lot less bloody. But people have a lot of tourniquet pain and stuff. So I try to minimize how often I use a tourniquet just because I think it helps with
right. And the specific robotic surgery is by a manufacturer called Stryker, and it's called the Mako. Is that correct?
Yes. So I use the Stryker Mako, which is a company, one of the biggest joint companies in the world. And it's just the one particular company I use. But there's actually all the major companies have a robot now or something very similar.
Okay.
Well, you had mentioned earlier that they last about 15 to 20 years. What decides that? Is it the material that they use, maybe the implant loosening, and or even how active the patient is?
Very good question. So I would say at this point, we call it, there is a newer plastic out. So we put metal in on the femur, metal on the tibia, and that hasn't really changed too much or evolved over the last 40 years. It's very similar. But the type of plastic that we put in is different. And so we call it a newer plastic, but it's probably been out for 20 plus years at this point, 25 years. And so they made the plastic harder and it wears down less. And so far the data on it is that it seems to be lasting a lot longer. The type of plastic we used, 40 years ago, 30 years ago that was invented, that would wear down and create little microparticles that would float around the knee. And then that can cause loosening of the prosthesis. So now we're not actually seeing the plastic wearing down as often, but what we are seeing is that where the implant is either cemented onto the knee, or if we are press fitting the knee without cement, that could come loose. So that's probably the main number one cause for revision knee replacement, is that the implant comes loose.
Did you use cement on my knee? Do you recall?
I don't think I did. I'd have to go
Probably
back.
the outdated material for sure, though, right?
It's the cementless knee replacement technique is really becoming a lot more popular, or it's being used a lot more commonly now, because we are trying to create a knee replacement that lasts as long as we can.
Sure.
Certainly.
And we're doing knee replacements on patients that are a lot younger than, say, maybe we did 30, 40 years ago, where the textbook answer was age 70 is when we would do the knee replacement. Now we're doing knee replacements in patients that are 50 and 60. And so, we want that knee replacement to go 25, 30 years.
Do you ever do any of these surgeries on children?
No.
Okay. Good to know. Do you see any differences in outcomes between different implant designs or manufacturers? Or is it the technique that really matters most?
I'd say the thing that matters the most is patient selection. And we can talk a little bit about that. But no, there are no major differences between the companies. So I happen to use Stryker, but all the companies work well. They're all FDA approved, and they, like I said, there has been nothing that shows that one type of implant is better than another.
Well, you talked about the different manufacturers. Does the surgery and the planning of the surgery vary from men and women, or children and people above 85? How does that work? Is it all the same? Pretty much, you approach it.
Pretty much the same. I don't think there's a big difference between men and women in terms of how we do the knee replacement. We touched a little bit about using cement versus going cementless. And so bone quality is important. So assessing the bone at the time of surgery when you're doing the knee replacement kind of helps decide whether you would use cement or not. That's a little bit subjective, and we're certainly trying to work and figure out which patients would benefit the most with a press fit design versus a cemented design. The cement is, of course, the gold standard. We've been using that for a long, long time, and it works.
You had mentioned that there's standardized sizes of the prosthetic knees, 3 or 4 or 5 different sizes. Do you think the future's moving more towards personalized or patient-specific implants?
I would probably say no, only because of cost. I think that healthcare is very expensive in this country. That's been well documented. And when you look at the cost of making a patient-specific implant or a custom implant, for example, there's certainly there's definitely an added cost versus we could trim the bone down. I mean, you can find sizes between number 1, the first size, and the number 8 size that fits almost everybody. So,
And insurance companies would certainly balk at that.
And because to answer your question, they do have custom implants. Those are out.
Well, they are. Okay.
Oh yeah, they're out, and so it is an option, but insurance companies want to control costs. So I would say, in a perfect world where resources perhaps aren't limited, yes, it would make a lot of sense to do a custom implant. But practically speaking, I think, and trying to be, prudent with our decision making in healthcare and trying to control costs, it probably not going to work out.
Dr. Leathers, if you could clear up one big myth or misconception about knee replacements that people have, what would that be?
That's a great question. I think that setting patients' expectations for what a knee replacement is and what they can expect coming out of it once they're fully recovered is important. So I think some of the myths that I would hear is that people come in and say, well, everybody that I know that's had a knee replacement has done perfectly well. No one has any problems. Everyone does great. And the answer is yes. 80% of people, 85% of people, it was the best thing that they ever did. They are satisfied. They don't regret their decision one bit. But the data is pretty clear. About 15 to 20% of people are not happy with their knee replacement. We're working on that, trying to figure out who falls in that 15 to 20%. But that's one of the things I try to educate people when it comes to making a decision on whether or not a knee replacement is right for them is really just giving them the information, trying to help them make an informed decision, because it's really a personal decision.
Where do you sit with that, John?
Well, I was going to add, thank you for asking.
Absolutely.
I'm only 2.5 months out for my surgery, which was December 1st. And you know what? Honestly, the jury's still kind of out for me. I have a new set of issues now. The pain that I was experiencing prior to the surgery is gone. But I have a new set of things. I mean, I have to re-strengthen my knee, a bunch of little things here and there. But all in all, I think it's going to be a good choice.
Good. Glad to hear that.
Yeah, but I'm still fresh. You know, I'm a newbie, and I hear 4 to 6 months years when you really start to appreciate the new knee.
Yeah, it's a good point. You know, you mentioned my dad earlier, who's a orthopedic surgeon. He's pretty much retired at this point, and but he's had 2 hip replacements and a knee replacement. And he told me after his knee replacement, when patients say that this surgery hurts, they're telling the truth.
Yeah,
I know how.
I can tell you.
Yeah.
Looking ahead 10 years, what do you think will change most dramatically about how knee replacements are designed and implanted and the rehabilitation process?
Well, we've come a long ways with pain control after surgery. So I just see that improving. I think that's one of the main differences between hip and knee replacement. Hip replacement, patients do pretty darn well, 95% patient satisfaction rates. Like I said, a little bit lower for knee replacement. So trying to close that gap, I think, is important over the next 10 years. And how do we close that gap? I think, again, it comes down to patient selection, patient expectations, trying to educate people so that when patients decide that they're ready for knee replacement, that it's the right thing for them and then they have a good outcome. The worst is having someone that is on the fence. They kind of get convinced or pushed towards doing a knee replacement. They don't have a good outcome and they're not happy. That's the worst case scenario. Yeah. So I see over the next 10 years trying to get patient satisfaction up after a knee replacement.
Good answer.
Technology wise though, I mean, the robotic assisted surgery is definitely gaining more and more popularity. Again, I don't know if that's going to solve the patient satisfaction component in terms of how long they last, trying to get them to last longer. It might be, but I think those are the things we got to work on.
Do you think there'll ever be a true lifetime knee replacement?
Gosh, I hope so. But you know, like everything in medicine, there is nothing that's 100%. So, you know, we're just trying to decrease complications, increase patient satisfaction, and certainly try and increase the longevity of these implants.
Oh, that's great.
I know we talked about this next question already a little bit, but just for clarity, are newer implant materials, today's materials that are used, are they actually lasting longer?
The plastics, yes, definitely. For the most part, the femoral component is made out of cobalt and chrome, and the tibial component is made out of titanium. So there are some companies that use a slightly different mix of metals. We talk a little bit about metal allergies. So some companies have metal that has a little bit less nickel and some other metals that might cause a reaction. But for the most part, they're pretty similar across the board.
Okay.
Interesting. Which patients are more likely to run into infection issues after the surgery? And is there something they can do before to prevent that?
Well, infection after a joint replacement is a devastating complication. It really is a big deal because almost in every one of those cases, the patient requires more surgery. So it's not something that's easily fixed with, antibiotics, whether it's in the IV or whether it's oral antibiotics. It usually is that combined with more surgery. And sometimes it even means taking out all of the metal implants.
Wow.
So huge deal.
Yeah.
And so trying to decrease your infection risk is huge. And so again, the number one way to decrease infection is having a healthy patient. The healthier you are going into surgery, the less likely you are to have an infection. So smoking, big one. Diabetes, uncontrolled diabetes, another big one. And just your overall health in general is important. The healthier you are, the less likely you are to have an infection. If you've got 4 or 5 different medical issues, whether it's heart attack, kidney disease, on dialysis, smoking, uncontrolled diabetes, those are all types of medical conditions that weaken your immune system and therefore can make you more prone to infection.
Well, what about post-surgery? I know the dentists sometimes require you to take antibiotics even before a cleaning. What are your thoughts on that? Is that something that you've heard about, or?
Definitely. So that's older recommendations that have been around for a long, long time. So like I said, because of how devastating infections are,
Sure.
As from the orthopedic surgery standpoint or the orthopedic surgeon standpoint, if giving antibiotics at the time of a dental cleaning, we would do anything to try and decrease that risk of infection. But the studies are clear and the recommendations are very clear from our academy that taking antibiotics before dental cleaning is not necessary. It does not decrease your risk of infection after a cleaning.
Well, that clears that up. Thank
Good
you.
to know. I go for a cleaning tomorrow.
Yeah.
There you go.
Not that they're dirty, but I don't know. Anyway,
Well, yeah, I didn't even know you went to the dentist.
I do occasionally.
Well, that's fantastic.
Okay, Snaggletooth, get on with it. Dr. Leathers, how do you balance encouraging an active lifestyle with, at the same time, protecting the longevity of the implant?
So I think low impact exercising is great. Riding a bike, swimming, walking unlimited, hiking unlimited. Certainly golfing is great. Tennis is fine. It's really those activities are all under, we consider those safe and encouraged activities with a knee replacement. It's just the higher impact activities that we would caution you about. Certainly there's been some famous skiers that have skied with partial knee replacements lately. And so it's doable. You can ski with a knee replacement. You can run with a knee replacement. It's just that we want you to enjoy that knee replacement for as long as you can. And so from a mechanical standpoint, the less force or pounding you put on the knee, that would maybe suggest that it would last longer.
But if a bear is chasing me, I can still run away from it?
I only have to run faster than you, John, so I think that covers that.
No, never mind.
Do patients actually do better with the robotic assisted knee replacement as compared to the regular knee replacement?
So right now,
have you seen any difference, or?
No, right now the outcomes are the same. So there are some differences between the robotic assisted knee replacement versus their conventional or manual instruments. And a lot of those differences have to do with postoperative x-rays and alignment. They found that the robotic assisted have, for lack of a better term, better looking x-rays or the alignment is perhaps better. But in terms of satisfaction rates, longevity rates, how long they last, there is no difference between robotic assisted and conventional
Interesting.
instrumentation. So
Okay, good to know.
But from a doctor's standpoint, does that help you? Do you feel like you're more confident going in there? I know you're already confident to be a doctor in the first place, but do you feel better going into the surgery knowing that you're going to have the...
Is that your preference, the manual or robotic?
So I probably do half of my knee replacements robotic, the other half manual. And to be honest, I actually enjoy using both, doing it both ways. I think we could pull up maybe the second video here and then we can talk.
A little graphic, folks, just a warning.
So we'll reference this as picture number 3.
Okay.
And so not to get into the weeds too much of this and make it easy to digest, is that the robot assisted knees, there's a lot of ways to manipulate how you cut and perform the knee replacement. And so we try to create what we call a balanced knee. So when your knee is fully straight, and then when it's at 90 degrees bent with a bent knee, you have a different, what we call stability between the inside part of your knee and the outside part of the knee. And we would like to create a balanced environment between both sides of the knee when either your knee is bent or it's straight. And so we plan the cuts around creating a balanced environment. And so I found that actually, I think I do a much better job now than I did before the robotic knee replacements came around using the conventional instruments. So by learning how to manipulate how you make your cuts robotically, it's aided me when I use my manual instruments. I'm more comfortable making those adjustments on my own because I've kind of seen what we can do robotically with it.
That's interesting.
It's kind of like flying an airplane, an autopilot, right, Dan?
That's right.
Dan is a retired airline captain with American Airlines, so he knows about robotics.
If you have any avionics or aviation questions, let me know.
Yeah.
I'll think about
I want to know how planes fly. I just don't get it. You know, these things
I
weigh
don't either.
thousands of pounds. What the
I
heck?
don't either. I'm like, there's a lot of physics going on there I don't really get.
Dr. Leathers, many patients notice that their knee after the surgery and they have the implant, that it clicks or pops when they walk, bend, whatever. What causes that clicking, and is it considered a problem, or at what point should they come back to you and say, hey, this thing's making noises. It's a one-man band.
Yeah, totally normal. You don't have to worry about that. Here's just a model of a knee replacement here. And again, I'll kind of try to show you some key things here about why it clicks and pops. So really it's the metal clicking against the plastic. And so totally normal. You don't hear that in an unreplaced knee because you have nice soft cartilage and bone. It just doesn't click like that. But the metal and plastic, it clicks.
There you go.
And so totally normal, nothing to worry about.
Okay.
And then just to kind of show you when I say it's a resurfacing, so if I take the implant off, we just trim the bone to fit this metal cap here. And so we put that on the femur. On the tibia, we just trim off enough of the bone on the tibia to fit this metal cap here. And then again, this could either be press fit, which means we kind of just press fit it into the bone and that allows the bone to integrate onto the implant, or we could cement it into place. And then we click in a piece of plastic, put the knee back together. So when you bend and straighten your knee, you have the metal rubbing on the plastic. So that's what a knee replacement is. It's just really a resurfacing. And then the rubber bands on the side, of course, are holding the model together, but really that's also to kind of mimic what we have naturally, and that's your MCL and your LCL, your collateral ligaments around the knee, and they give support with side-to-side stress.
Well, if the collateral ligaments that you call them, if they're stretched out or weak, is there something you correct during surgery for that, or is that important at all?
So again, that gets into the balance. So of course, everybody has some difference in laxity between the medial and lateral sides, or the inside and outside part of your knee. So we can angle the cuts or angle the way we put the implants in to fill the gap so that they even out. Or we can use a different plastic that has some stability in it. So in this particular type of an implant, it's called a posterior stabilized implant, but there's a cam here in the middle, and they make different sizes where it actually adds in stability so it can become thicker. So if someone truly had an absent collateral ligament, or their MCL was not able to function normally, which is very rare, you can put that in, and it would provide or make up for that ligament.
Oh, that's
so there's different types of implants that can do that, revision style implants, but conventionally.
That's amazing. I don't know how you do it.
Thanks for simplifying that for us.
Yeah. John, did you get that?
There's no quiz, is there?
I was taking notes. I'll have to refer to
There
it
you
later.
go.
Absolutely.
Before a patient undergoes a total knee replacement, how do you evaluate whether they may be allergic or sensitive to any of the implant materials? Is there some kind of a test you do?
So there are tests, blood work, as well as patch tests that could be done to look for metal allergies, or sometimes patients might have an allergy to the bone cement. But that is not routinely used. I would say the best test is people have all had jewelry on in some fashion, whether it's watches, rings, earrings, and if they've necklaces, bracelets. So they've been exposed to metals in the past, and if they've had strong reactions, that's one of the most important things to kind of assess when you evaluate someone before surgery if they have a metal allergy. It's pretty rare to have a metal allergy.
Okay.
Interesting. I got a question for you. Dr. Leathers, thank you so much for being on the show. How would someone get a hold of you if they found this information valuable and come to know you like John and I have, and found out you're just a really nice guy?
And you're serving Northern California, Sacramento specifically, but I
do they get a hold of
assume
you?
a lot of your patients go to outreaching areas, right? Or do they come from overseas too?
I'm trying to think.
Is the word out?
The word is out. But I live and I practice in Sacramento, California. I'm in the downtown area. You can find me on my website. It's just www.leathersortho.com. Of course, you can just Google my name, Michael Leathers, MD, in Sacramento, and I should pop up. Right? Yes, I'm junior. My dad's senior.
That'll always stay, I guess.
I think that'll always stay.
Well, Dr. Leathers, quick question. Are you specific to one certain hospital, or what hospitals do you work with?
So I have a private practice in the downtown Sacramento area. So I work out of both Sutter Medical Center, Sacramento. So I take anyone with Sutter insurance, as well as Dignity Health at Mercy General Hospital. So all the major HMOs, PPOs, Medicare plans in the Sacramento area I take, and work out of both Dignity Health or Sutter.
Well, that's good to know. And at this point, I'd like to personally thank you for being on our show. This has been really informational.
It's really been great. Thank you, Dr. Leathers.
Great.
Appreciate all your information. And again, thank you for making my knee whole again.
That's right.
Absolutely.
And especially thank you guys out there for watching the podcast.
Yeah, join us. We're going to have more exciting guests like Dr. Leathers coming up in the future, y'all.
That's right. You guys have a great day. Thank you very much.
Two old guys with some tales to share. John and Dan, unscripted and rare. They talk about life and everything under the sun. You never know where they'll go.